All right, we're doing knee palpations. First knee palpation is the joint line and the meniscal windows. First, we're gonna have our patient lie down supine with her leg bent at the knee joint. And then what we'll do is we'll grasp the proximal posterior lower leg with the fingers. And then you're gonna find the patella tendon and place both thumbs on either side of the patella tendon. Follow the depression medially and then laterally. This depression is the joint line. Next, we have the medial tibial plateau. First, we'll have our patient lie supine with leg bent at the knee joint. Then we will grasp the lower leg from the front, and then with your fingers in the popliteal space and thumbs in the depression of the joint line. Next, if you press inferiorly, you will be palpating the tibial plateau. And on the medial side of the patella is the medial tibial plateau.
Next, we have the tibial tubercle. If you follow the infrapatellar tendon distally, it will insert onto bony prominence. Where it inserts is the tibial tubercle. It is also the insertion of the pes. Next, we have the tibial tubercle. If you follow the infrapatellar tendon distally, it will insert onto bony prominence. Where it inserts is the tibial tubercle. It is also the insertion of the pes anserine.
Next is the medial femoral condyle. Have the patient supine with leg bent at the knee joint to 90 degrees. Place thumbs in meniscal windows if you press upward on the medial side of the patella with thumbs still in joint line. You will be palpating the medial femoral condyle. Next, we have the medial femoral epicondyle. With the patient's leg bent at the knee joint, beginning on the medial femoral condyle, palpate medially. You will feel the sharp edge of the medial condyle. If you palpate further medially to that, you will be on the medial femoral epicondyle.
Next, we have the adductor tubercle. Beginning at the medial femoral condyle, palpate medially and posteriorly until you feel a bony prominence at the distal end of the natural depression between the vastus medialis and the hamstring muscles. This is the adductor tubercle.
Next is the medial meniscus. Have the patient sitting with the leg off the edge of the table, internally rotate the tibia, and palpate along the medial joint line. With internal rotation, the meniscus pokes out a little bit, and you should be able to palpate a soft prominence that is the meniscus.
Next, we have the medial collateral ligament. This is a broad fan-like band that connects the epicondyle to the tibia. The medial meniscus is also connected to the MCL. The ligament itself is not distinctly palpable unless symptomatic. To palpate the region of the MCL, locate the medial joint line in the meniscal windows. From there, move medially and posterior along the joint line, and this should be the region of the MCL and will become tender if there is a sprain and a defect is felt. Usually will indicate a tear of the MCL.
Next is the pes anserine. Have patients sitting over edge of the table. Stabilize the patient's leg by holding their leg. Palpate the tibial tubercle. Move slightly medially and posterior. Ask the patient to attempt to flex their knee while you resist. This makes the tendon more prominent. These groups of muscles and tendons are known as the pes anserine. Just medial to the insertion under the tendon lies the pes anserine bursa.
Next is the lateral tibial plateau. Have your patient supine with leg bent at the knee joint. Grasp the lower leg from the front with fingers in popliteal space and thumbs in the depression of the joint line. If you press inferiorly, you will be palpating the tibial plateau. on the medial side of the patella is the tibial plateau. Alright, next we have the lateral tubercle, the large prominence of bone right below the lateral tibial plateau. Palpate the patella tendon and then move laterally from there.
Next, we have the lateral femoral condyle. Must have the knee flexed past 90. Palpate its smooth surface right below the lateral to the patella. Next, we have the lateral femoral epicondyle. Lies lateral to the femoral condyle.
Next we have the head of the fibula. From the lateral femoral epicondyle, move your fingers inferiorly and posteriorly, following the joint line. The head of the fibula is at the same level as the tibial tuberosity, but is on the lateral side of the leg.
Next is the lateral meniscus. Easiest to palpate when the patient's knee is slightly flexed. Probe firmly on the lateral joint space with your thumb, and you may be able to feel the anterior margin of the lateral meniscus. Next, we have the lateral collateral ligament. Best to palpate with the knee flexed to 90 degrees and the hip abducted and internally rotated. A thick cord-like structure that runs from the lateral epicondyle to the fibula head. Next, we have the biceps femoris tendon. Have patient with their knee at 90 degrees. The biceps tendon is the tendon on the lateral side of the knee that comes down and inserts on the fibula head. It becomes more palpable when you resist knee flexion.
Next is the iliotibial tract, or the IT band. It is on the anterior lateral side of the knee. There are two ways to palpate. First, have the patient seated or could be standing, and could tell them to dig their heels into the ground. It should be prominent. Second, have patient with leg fully extended, like he is now. Regardless, either way, the IT band should be more visible with leg fully extended. Alright, next we have the common peroneal nerve. Palpate across the neck of the fibula head. Next we have the trochlear groove. The trochlear groove is the track that the patella glides on. To palpate, the patella will have to move laterally or medially.
Next, we have the patella. It's the largest sesamoid bone. Next, we have the patella, the large sesamoid bone that glides over the knee joint, commonly called the kneecap. Next, we have the quadriceps tendon. The quadriceps tendon runs from the end of the quadriceps muscle to the superior pole of the patella. The tendon encompasses the patella. Next, we have the patella tendon. The patella tendon is from the inferior pole of the patella and inserts on the bony prominence of the tibia.